Thank you for inviting me to speak, Ashley, and I just wanted to speak through a patient lens. This is Sarah. Sarah has neck pain, headaches and paresthesia in her arm. She's actually one of our real cases, someone that I saw in my clinic on Whiplash Navigator. After musculoskeletal injury, Sarah has the most common symptoms that people experience, ranging from neck pain, but also psychological distress. From what you heard this morning, you will know that what happens with whether people have physical or psychological injury, they experience the same pain. So someone with whiplash or neck pain has exactly the same pain pattern as someone with sexual assault, yet they're injured very differently. And this is the work of Sam McLean some time ago. Sarah's pathway is not great. She'll see an ED, she'll go to a GP, a physio, multiple medical specialists, costing thousands of dollars with lots of referrals. And we know that when we look at the healthcare expenditure, because most of that for musculoskeletal injury is spent in public hospitals, in private hospitals, with medicines, with surgery, and not with allied health. So we asked that question, how do we know when someone who's had a musculoskeletal injury is at risk of both poor physical and psychological recovery? Do we know that up front? In the guidelines that we produced a couple of years ago now would say, actually we do, and tools are pretty good at us being able to predict who will do well and not so well. And they're derived from known individual factors that predict poor outcome that you can see listed on the screen, high levels of pain, high levels of disability, but also psychological distress. So we might use one of these tools with Sarah, the Cerebro, and you're probably familiar with it. And the Cerebro here tells us that Sarah's score's 55. She's at moderate risk of non-recovery. But we might ask Sarah some more questions. Sarah, you mentioned you can't sleep at night. What's that about? Well, I'm getting nightmares. I'm getting flashbacks. You just heard about what that means previously. Sarah, you've told us you feel anxious. Tell me what's making you feel anxious. But I'm anxious. I can't get in the car. I don't want to get in the car. I don't know if I'm going to recover. This puts Sarah at medium to high risk of poor recovery. And the question we ask is, well, who should Sarah go and see now? We know from our psychological colleagues that it's really hard to see psychologists in this context. They're working flat out, as you can see already, dealing with more moderate and severe conditions. We know, however, that physiotherapists, for example, can provide psychologically safe care very simply. So who should Sarah see? We tested this in a Australia-wide clinical trial involving 700 odd people. And I'm just going to show you the patient experience and clinician adoption of this pathway. And what it was that people like Sarah, who are at medium or high risk, went to see a physiotherapist as opposed to an orthopaedic surgeon, which is the usual pathway. And we wanted to see if the care thereafter would be a little bit more sensible, I guess, for Sarah. And so, maybe not seeing a surgeon. And so what happened there was when should Sarah stay in primary care? When can she be seen by a more specialist physio? And when should she be referred to a psychologist? Our psychologists help. We might need the sound up on that. Is that possible? Or are we not going to have it otherwise?
Psychologists, I would say at least 65 would be the time we should consider that. So 65 out of 100. Yeah. That equates in our studies to about the top sort of 25% of on the bell curve, and those are we need to have a closer look.
So just repeating that, so then we can use tools like that to say if people are scoring higher or 65, for example, they should see a psychologist. The post-traumatic stress diagnostic scale, the one that's recommended for people with musculoskeletal injury such as Sarah, also our psychologists would say, actually, you can manage them if they're below 34 or so, but as soon as they're above that, maybe we need to take a look at that. And what do patients think of this new model of care? If you look at the green little bubble there, they said, well, actually, physiotherapists that are trained in this provide more holistic care. They're the first physiotherapists that even touched on the mental health. And we saw in our adoption outcomes here that we did see less of that unnecessary, or de-implemented the unnecessary care, both imaging and inappropriate referrals to surgeons. So we saw the right type of outcomes. There's increasing evidence for this in clinical trials across both whiplash and in chronic low back pain, where more simple psychological treatments can be delivered safely by alternate allied health care professionals. You might want to know more about this in our resources. And many of you will know that we're undertaking an Australia-wide clinical trial now in rural Australia, my passion to be able to bring this to the bush as well. What I wanted to do before I finish is just invite one of my colleagues, Jade, do you want to come to the stage to talk about another example within our health district of allied health? And Jade's a social worker, and how she's delivered models of care and expanded roles. Go, Jade.
Thank you, Trudy. In the Northern Sydney Local Health District, our Emergency Department to Community, EDC, program asks a critical question. How do we reduce frequent presenters, ED presentations, when systemic gaps remain? Frequent presenters are those attending ED 10 times or more in a year, making up around 5% of our ED users, and they consume a disproportionate amount of resources. Many experience mental health, trauma, homelessness, substance use, and fragmented care. These are not just medical issues, but they're psychosocial issues. Established in April 2024, the EDC program is a 2-year pilot aimed to reduce avoidable ED presentations by addressing the social determinants of health. Our social work nursing-led model focuses on person-centred, proactive care through case management, home visits, ED inreach, collaborative care planning, and advocacy. In one cohort study, we saw an 80% reduction in ED presentations, where we avoided 585 visits. Patients received consistent care, and with the development of collaborative ED management plans with ED, ambulance, the patient, and other stakeholders. This work demonstrates that the critical role of allied health in addressing the social, psychological, and environmental factors that drive ED presentations. Improving mental health and well-being is more than clinical treatment. It's about connection, continuity, and compassion. That's what the EDC program delivers. Thank you.
Thank you. I'll let you go. So Jade would like to acknowledge the people on the screen in that work. So in closing, I guess, we've thought about this, and the work that I told you before was done in primary care, and I now have a role in the public health system as well. And when we look at allied health care, they might say things like this, and this is a scope of practice study underway. Exercise physiologist, well, we do 2 or 3 hours worth of lectures on it, that's about it. A speech pathologist, well, we provide cognitive behavioural therapy with breathing and throat training. You know, it's within our scope, but to a point. I'm going to finish in 1 minute, even less, but to a point. A psychologist, but they say they can do CBT, but they do a few hours of training, and we've done 2 years of it. So who should do it? Another psychologist, well, it could be appropriate if they don't have a psychologist within their team. So maybe they do need to do it. So it's a question, isn't it? It's a blurring of those lines. And so I think my acknowledging my team, should have come last, but the question that I wanted to get your views on or thoughts on, and maybe in the break, is that. So is there a role for an expanded role for allied health to improve psychological health? And where's that line in the sand? What is it that other allied health clinicians that people can access better can do so that we can have a sustainable workforce, versus what is it that we do need to refer to psychologists? And that's the question I leave you with, and the one that I'm trying to answer. Thank you.